Good afternoon. My name is Bridget Walsh, and I'm a Senior Policy Analyst at the Schuyler Center for Analysis and Advocacy in Albany. Welcome to the Moving on Maternal Depression webinar series presented by the Schuyler Center and the Postpartum Resource Center of New York. Due to this trying time of crisis, we are beginning this series with a special edition addressing perinatal mood and anxiety disorders in a time of coronavirus-19. The Moving on Maternal Depression project is part of a larger national learning collaborative. We are looking at advancing policies that improve prevention, screening, and treatment with an emphasis on racial equity and culturally relevant services, practices in policy and systems change. There are a number of resources available on the Maternal Depression Project on the Schuyler Center website, and today's recording and slides will also be posted here. With that, I'd like to turn this over to Sonia Murdoch from the Postpartum Resource Center.
Thank you, Bridget, for having me here today, and I would look to see about sharing my slides right now. We're a statewide nonprofit helping New York State moms, dads, and families get to the help they need since 1998. And how we have been addressing further helping moms and families during this time of crisis is the expansion of services and letting New York State moms, dads, and families know about different supports that are there for them during this time of crisis. The Postpartum Resource Center of New York, we now have expanded our statewide helpline to 7 days a week. 7 days a week, we are offering New York State moms, dads, and families free and confidential emotional support and further helping get them to the help they need. We're providing them with patient education as well as with peer support from moms who've been there. So very important to connect moms to other moms and give them the support they need at this time. We have our statewide helpline and website. We are also the lead state coordinator. Thank you very much, Bridget, for having me here today. And with the Postpartum Resource Center of New York, it's our great pleasure to be here today and to further share with you the importance of helping New York State moms, dads, and families get to the help they need for perinatal mood and anxiety disorders. As a result of the coronavirus pandemic, the Postpartum Resource Center of New York, we now have expanded our helpline services. We have a statewide helpline, and we are now available 7 days a week, providing free and confidential, non-judgmental emotional support, educational information, healthcare, and support group resources. It's very important that these moms, dads, and families get educational information and further providing them with peer support from moms who've been there. We have moms on call telephone support 7 days a week, as well as family telephone support. With our statewide helpline, we also have the information on our website. We are also the lead New York State coordinator for Postpartum Support International, the worldwide organization for perinatal mood and anxiety disorders awareness and support. It's our great pleasure today to be featuring the Motherhood Center of New York with guest speakers Dr. Catherine Berndorf and Paige Bellenbaum. The Motherhood Center of New York, as Dr. Berndorf and Paige will be sharing with you, has uniquely addressed the services that are being able to be provided, and we want to make sure that New York State moms, dads, and families know that there is help available for them. I'd like to introduce everyone to the guest speakers today. Dr. Catherine Berndorf is a reproductive psychiatrist who is the co-founder and CEO of the Motherhood Center of New York, a treatment center for pregnant and new mothers experiencing mood and anxiety disorders. Dr. Berndorf is founding director of the Payne Whitney Women's Program at the New York Presbyterian Hospital Weill Cornell Medical Center, where she is clinical associate professor of psychiatry and obstetrics and gynecology. Dr. Berndorf is a board member of Postpartum Support International, a nonprofit organization for awareness, prevention, and treatment of mental health issues related to childbearing worldwide. For 10 years, Dr. Berndorf was a regular mental health columnist for Self magazine and has appeared on numerous television programs, including The Today Show, Good Morning America, MSNBC, and CNN. Her first book, The 9 Rooms of Happiness, co-authored with Lucy Danziger, was a New York Times bestseller published in 2010. She is the co-author of What No One Tells You, A Guide to Your Emotions from Pregnancy to Motherhood, published in April 2019. She is joined by Paige Bellenbaum. Paige is the founding director and chief external relations officer of the Motherhood Center of New York. Paige started her social work career working at a homeless shelter for families in San Francisco, where she built a multi-million-dollar housing and aftercare program for families transitioning from homelessness to permanent housing. She then moved to New York City in 2000 to get her master's of social work at Columbia University. After she graduated, she held executive level positions at various nonprofit agencies, including the Center for Family Life located in Sunset Park, Brooklyn, Habitat for Humanity, New York City, and Settlement Housing Fund. Throughout her nonprofit career, Paige has worked with homeless families, victims of domestic violence and child abuse, formerly homeless single mothers, formerly incarcerated young adults, and more. She chaired the Youth and Human Services Committee of Community Board 6 in Brooklyn for 6 years, and ran for public office and was elected in 2015 as the district leader for the 52nd Assembly District in Brooklyn, which she held for 3 years. After Paige's first child was born, she suffered from severe postpartum depression that nearly ended her life. Once she began to heal, she became committed to fighting for education, screening, and treatment for postpartum depression so that no more women would have to suffer silently. She drafted legislation in New York State that was championed by New York State Senator Liz Krueger, mandating education and strongly encouraging screening of all new and expecting mothers that was signed into law in 2014. Paige has been an outspoken advocate on the issue of postpartum depression and uses her own story as a tool for change. She has appeared on The Today Show, NPR, PBS NewsHour, and Women's Health Magazine. It's a great pleasure to welcome Dr. Berndorf and Paige. Thank you.
Thanks for that. Lovely introduction, Sonia. And thank you, Bridget, for giving us this opportunity to be a part of this important moment. All right, I'm just gonna pull up our presentation here so we can go ahead and get started. All right, well, I just want to start by saying I hope everybody that's viewing this that you and your families are safe and healthy, and that we all feel confident that we will make it to the other side of this. And I also want to offer the fact that if ever there was a time for mental health support and care, it's now. My colleague, Dr. Berndorf, has referred to this on several occasions as a mental health crisis, and it is. And it's a particular crisis for new and expecting mothers that are not only battling perhaps a perinatal mood and anxiety disorder, which we'll get into in a moment, but also the overarching anxiety of what's going on right now in the world, and how important it is for us to be able to touch this population with adequate care. A little bit about the Motherhood Center. We are in a bricks and mortar iteration located in New York City. And we aim to effectively diagnose and treat women suffering from perinatal mood and anxiety disorders. From here on out, Dr. Berndorf and I will be referring to this cluster of mood and anxiety disorders as PMADS. That's the acronym we have for it. We don't love it. Someday, hopefully we can change it, but it's what we have for now. And most people recognize PMADS as postpartum depression. That's kind of been the catch-all historically. So Dr. Berndorf, do you want to spend just a moment walking us through briefly what PMADS are?
Absolutely. Thanks, Paige. And thank you for having us in this forum. It's so important to get the message out, particularly as PMADS still exist, even though the whole world's in crisis. And I feel like now more than ever, it's getting confusing. So there are still PMADS in the time of coronavirus and COVID-19. So I'm thrilled that we're able to talk about them at this time. But as Paige alluded to, we're using an acronym called, perinatal mood and anxiety disorders, PMADS. And it's sort of the new post-PPD. PMADS are the new PPD, right? What was postpartum depression, and we would all wonder, do we have that or not? It didn't include everything. So in a way, even though the acronym, we don't love that it has the word MAD in it, but it is far more encompassing. So we like that part of it. These are groups of illnesses that affect at least 1 in 5 women during pregnancy and the postpartum, and cause both emotional and physical problems that make it hard for women to function adequately. And we're going to talk, I think we get to talk today about all these different ones: perinatal depression, perinatal anxiety, perinatal OCD, perinatal PTSD. And while you notice those are all perinatal, we really refer to those during and after pregnancy. We keep postpartum psychosis in the after pregnancy piece, although please know that any of these mental illnesses or mental health issues can be present before, during, or after pregnancy. So in some ways, the perinatal piece is really defining the timeline. And you see a little bit about each one of these here. You can read those. I won't read them all to you. We're going to talk a little bit more about them in some slides coming up.
Great. So want to spend a minute just talking about why PMADS are important. As Dr. Berndorf referenced, 1 in 5 women experience a PMAD in the perinatal period. And what I always like to throw in is that's what the statistics prove. Because of the overarching stigma that surrounds PMADS, so many women do not come forward. And so if you're to take them all into consideration, those of us who do this work, we think it's probably more like 1 in 3 that experience some level of a PMAD. 80% of cases go undiagnosed, again, because of the stigma, lack of awareness, and a real dearth of specialized treatment services and options for women that are experiencing PMADs. Up to 40% of low-income women experience a PMAD in the perinatal period, which is just an astronomical number. And again, although we don't have any data to support this because we're living in the time of coronavirus now, I would venture to believe that all of these numbers are going up much higher considering the anxiety that everybody's living under right now. As Dr. Berndorf mentioned, 50% of PMADs develop during pregnancy, and they are the #1 complication associated with childbirth. Untreated PMADs can lead to poor mother-baby attachment and developmental delays in children. They are the #2 reason for maternal mortality in the US. And in most severe cases, if a PMAD goes untreated, it can lead to suicide and/or infanticide. And these are the hardest stories to hear, and unfortunately the ones that typically make it into the newspaper, and the tragedy that if we were to intervene earlier, most likely would have been able to interrupt. There's a couple of risk factors that we know to be true. Women that have a history of mental illness personally or within their family are at a greater risk for developing a PMAD. Stressful life events and circumstances, finances, relationships, physical and sexual abuse, substance use, recent or unresolved, I can't read my screen, loss, and the coronavirus I wanted to throw in because this is certainly an external factor. If somebody's had a previous PMAD with a child born previously, they stand a 50 to 75% chance of repeating that diagnosis. Unplanned or unwanted pregnancy can lead to a PMAD, and traumatic birth or a NICU experience can also contribute to a perinatal mood and anxiety disorder. Dr. Borndorf, one thing I wanted to mention is in regards to just spending a quick second on each one of those diagnoses. If you want to do that now, I did rearrange some of the slides, so maybe just spend a quick second on the key PMADs and what some of those symptoms look like.
Okay, can I fly back to that other slide?
Sure can.
Thank you, Paige.
There we go.
Okay, awesome. So perinatal depression, again, this is depression in the perinatal period, right? It can be during or after pregnancy, and it can have existed before when you're going into pregnancy. So typically low mood, sadness, helplessness, hopelessness, a feeling of worthlessness, guilt, difficulty sleeping, eating, changes in some of those somatic bodily functions, typically define what depression is, right? And same criteria exists, that you have to have more or less of those symptoms over a 2-week period of time, more days than not. So perinatal anxiety, and again, this is a catch-all a little bit, because within anxiety disorders, we have panic disorder, we have generalized anxiety disorder, we have specific phobias, but what is consistent in all of them is worry, is the idea of intrusive thoughts, of concerns, of rumination. The experience of not being able to turn your brain off is often quoted by women. Not being able to sleep when the baby sleeps is one of the things we often ask perinatal moms or postpartum moms. And then perinatal OCD, which, by the way, OCD used to be part of the anxiety disorder spectrum. In DSM-5, it's become its own category with other illnesses. And obsessive compulsive disorder, right? You can have the O, obsessive thoughts, or you can have the C, which are the compulsive acts, or you can have both. You don't need both to define this. Rituals that one does. There's avoidance of obsessive stimuli. And again, these can be to the point of near without insight, let me put it that way. So we see particularly in the postpartum and during pregnancy, we are seeing a real, we see this at the Motherhood Center frequently, OCD to the point where the mom is so focused on one aspect of something that it's almost to a level where they've lost insight. It feels psychotic, but we'll talk about that another day. PTSD is not uncommon. Tension, nightmares, flashbacks, re-experiencing the birth. Birth in general, is a potentially traumatic event. It's also amazingly beautiful, but both things are true. And I think for women who have previous trauma, particularly sexual trauma, labor and delivery is an incredibly fraught time, and we are seeing plenty of PTSD, acute stress, and also post-traumatic stress in the postpartum period. And then postpartum psychosis, which is an absolute medical emergency. It is psychosis it typically happens within the first couple of weeks to a month of delivery. It can present later. We have seen some very unusual presentations, but this is an emergency because when it's not recognized or not treated, it can lead to infanticide or suicide. and or homicide in whole families. So it is a real emergency. This requires psychiatric hospitalization almost invariably. And, you know, women will have delusions, hallucinations, paranoia. They will appear disorganized. Sometimes there's an organization in parts of their life, but then a disorganization in other parts. So it can be very confusing. They feel confused, and those who are seeing it can also be confused by it. So an absolute emergency that needs immediate treatment.
Thank
Thanks,
you,
Paige.
Dr. Berndorf. I'm going to attempt to move us back to where we were. So what we want to spend the rest of today speaking with all of you about is, like many businesses across the United States and the world, in an effort to continue to provide very necessary service right now, we have moved our entire operation to a virtual platform. Had you told me 2 months ago that we would be running a virtual partial hospitalization program, I would have chuckled. We are doing exactly that. Everything that we offer at the Motherhood Center that originally was being provided out of our bricks and mortar location in New York City is now virtual, which is so interesting. I keep trying to encourage my clients and others to try to find the silver lining in everything that's going on in the world right now. And I think the silver lining for us was that providing virtual treatment was always kind of a like, oh, maybe next year. Oh, we'll get there someday. And here we were forced to become virtual in literally a week, and we did it. And if what a testament to an amazing staff and the ability to really dive into this, coming from a place of wanting to ensure that the most vulnerable new and expecting moms in New York City and beyond, because now that we're virtual, it gives us the opportunity to treat women outside of New York City, get the treatment that they so critically need. So Dr. Berndorf is going to walk us through our virtual day program, and then we'll talk a little bit our outpatient treatment services, support groups, and webinars. So Dr. Berndorf, tell everybody about our new virtual day program.
Right. It is new. Boy, this whole thing has been a lesson in creativity and flexibility, but that's what we're good at the Motherhood Center. So we prepared a couple of weeks before. We saw the writing on the wall, and we started to worry about our mothers coming into the center with their babies. We started to see people having coughs and not feeling well, and thinking like, oh boy, we need to protect everyone. We need to protect our staff, and we need to continue treatment, right? First and foremost, we wanted to make sure everyone was safe and well. And then how do we continue this treatment so that women who are, you know, experiencing moderate to severe PMADS can continue to get the help they need. So as Paige pointed out, on March 16th, we were up and running fully virtual. We had our last day in brick and mortar on the 13th. Women were so distressed that we were moving to this because it seemed kind of early. They kept saying, well, we'll just come in. It's okay. This is our only safe place. It was really interesting. It was heartbreaking, but I got to tell you, now it wouldn't have been an option, obviously, but everyone has gotten behind it. And I would say the 11 mothers who moved over with us from brick and mortar to virtual have been pleasantly surprised, as have staff. So I really feel grateful to everyone trusting that we could do this and get it up and running. So we're providing the same high quality treatment. It's intensive. It's 5 hours a day, 5 days a week. And these are women who are pregnant and postpartum who are having the more acute symptoms, as I described before, of anxiety, depression, bipolar illness, PTSD, OCD, and postpartum psychosis. And the only requirement is that you have to meet criteria, enough criteria to warrant being treated at this level of care, and not need an inpatient hospitalization. So you can't be actively suicidal, but we have plenty of women who have, you know, passive suicidality, the wish to escape, the feeling of being trapped, and the wish that they had never done this, i.e. having had a baby. So it's really profound, and we feel like we are able to support these women in an environment where they can speak the truth and be supported. We are doing it now, particularly in this time with everyone with so much unemployment. We've never been working harder, but that's okay. We are committed. This is what we do. We consider ourselves essential and frontline. We are offering a lot of what we were providing, you know, a month ago at a reduced cost. So we are really trying to make it work for absolutely everyone in our partial hospital program, we work with every insurance. So we make it possible for women to work with us. And we're really, people always say, you know, are you out of network? Are you in network? There is actually no network because we are doing something that has not really been defined outside of a hospital system. So we are working towards that. But until then, what we do is we fight for every single mother that calls us to get into our program and have it be affordable. So please feel free to send people our way, and we will do our best to make that happen. We believe that this kind of care is essential and needs to be everywhere. And maybe with Tela, we're going to be able to do this in many more places. But for the moment, we're fighting for each individual on a case-by-case basis to get them some help and the help they need. We're using Zoom, although there have been some questions about this platform recently. So we're staying up to date with state lines and the waivers and the wonderful flexibility that the federal government and state governments are showing to really help us treat women everywhere who need this kind of care. There's been an amazing outpouring of support and flexibility. I know I keep saying that word, but it's really not something I could have imagined. You know, even last week, things are changing on an hourly, daily basis. So it's pretty cool.
And also with OMH, I would add,
Yeah.
at least once a day, if not multiple times a day, OMH has been doing a fabulous job of keeping all of its providers. We are in Article 31, licensed by the state of New York, up to date on every, as Dr. Berndorf said, changing in real time regulations and policies that we need to do so that we're making sure always that the care that we are providing is meeting the bar, exceeding the bar.
But in compliance, I think is where you're going, right? That we are in compliance with OMH. And that is, they govern us, they manage us, and they have been so incredibly supportive of our program. And we are, again, feel very grateful that so much latitude is out there to help women everywhere. So, right, so I've sort of spoken a little bit about this, right? To prevent worsening of further illness and to help women that really couldn't get care. There's just not enough care that they can get on an outpatient level. We developed this program, and some of the things that we do within the program, and these are just like high level, we do skills development to manage acute symptoms. We do dyadic interventions, which is a mother-baby kind of therapy, or mother pregnancy. How do you feel about your growing baby? So we talk a lot about how women feel in terms of bonding and attachment. People come to this from all walks of life, and it's very complicated, right? What was your relationship like with your mother, and what will it be like with your child? Very complicated and very much impacts mental health. I do a lot of medication management, right, to mitigate mood and other mental health issues. And we have a whole team of licensed clinicians, psychiatrists, psychologists, social workers, expressive therapists, licensed expressive therapists, who are working together to treat this cadre of patients. And like I've said before, right, you have to endorse moderate to severe mood or anxiety symptoms that impair daily functioning. I'm doing a lot of, page 2, we're doing a lot of conversations with media outlets about what's the threshold, right? When do you know if there's a problem? And really what it comes down to is there has to be a lot of distress, right? So marked distress, and also dysfunctionality, right? That there has to be impairment. So people can have symptoms, and there's all, many of us right now are having subclinical symptoms because we all feel so anxious and unsure and uncertain and sad at times. And there's a variety of emotions swirling for all of us. And I think that's making it even harder for these women to come forward and say, but I feel like my partner may feel. How do I know that it's something more? So I think it's that something more question that's so important for all of us to be talking about, because it really has to do with the level of dysfunction and the level of distress, right? If you're thinking about things all day long, like on this list of obsessional ruminations, right? You may have an obsessional thought that comes in and out every once in a while. But if you're having that and it's taking up a lot of your time and it's keeping you from going to sleep, that's a problem that needs to be further investigated. If your sleep is not as good as it used to be and your appetite isn't either, that's okay today, but is it so bad that it's really impairing your functioning and you're losing weight, not trying to, or you're really not sleeping and able to function as well during the day. So all of these common symptoms that are listed here, including passive suicidal ideation, which I referenced before, depressed moods, panic attacks, irritability is seems to be the norm all around. We're all living on top of each other, trying to figure out how to work within this period of time. It's that much harder to have a new baby at home or to be pregnant and not feeling well. And scary thoughts, right? Feeling of harm coming to the baby or to oneself is not an uncommon thing that we see. So our goal within the day program is to stabilize the acute symptoms, is to prevent inpatient hospitalization. And we really, our goal, we've always had a nursery on site, and now we have a virtual nursery, which is, again, who would have thought? We have our nursery director and our nursery, some of our nursery staff and Paige are doing these one-on-ones with patients and babies, and they're doing individual sessions. It's just, and we're doing the dyadic treatment in the group form. So we're offering probably more services in a virtual capacity than we ever did, because women are really needing the support because they are feeling isolated, and they are isolated, but when you're together on the screen, there's a real feeling of camaraderie and creating that cohort for support. So like I said, we're reducing acute symptoms, we're increasing coping skills, addressing the bonding, stabilizing the family system. We do family therapy, we do couples work. So we're doing all kinds of things to help within the day program. And what we are doing, some of the therapies we use, this is a list of those. We do IPT, interpersonal psychotherapy. We use a CBT model. We use DBT, both skills and other aspects of that model. We do trauma-informed movement. We have a DBT therapist running our art therapy. She's dually licensed. We do the dyadic work, as I spoke to, and Paige runs the partner support group, which is very well attended and very meaningful to have the partners get their own space within the program. So in addition to each of these, patients receive, right, a comprehensive psychiatric evaluation and a psychosocial assessment when they come in. They have a treatment plan. They have treatment goals that gets updated. Risk assessment is absolutely a primary right now. Safety planning, we're doing more than ever because we can't be in the room with a patient. We need to know where they are, what their address is, what their emergency services are, who's around. We're taking it to like a whole new level so that our clinicians feel that they can find that safety for the patient if that comes up. They are seeing, so risk assessment is happening daily. We're doing med management weekly. We do individual therapy, like I said, family therapy. We collaborate with other providers, virtual nursery, after hours support that we all staff. Got the partner support group, and then we do a lot of discharge planning to ensure that people, after they've had this level of treatment, that they get to the next step. And we do offer an aftercare program so that women can do a little bit of a step down from us to a next level before they are only back out in their outpatient treatment. So I've already spoken a bit to this. I don't have to, I'm sorry to speak so much. These are just some, you'll have these slides, but you know, this is why some of this is important, right? Why it's so important that attachment and bonding are really the basis of what we're doing. We really are trying to help things now, but also prevent things for the future. There's such a long-lasting effect for babies and for moms who can figure out their connection and learn to be together in this way that's healthy. And we see this as like impacting generations to come. So we feel like this is the foundation of our treatment at the Motherhood Center.
So I can jump in and give you a breather, Dr. Berndorf.
Thank you.
You're welcome. I want to just second what Dr. Berndorf said about the understandable unease of transferring, especially with this cohort, many of whom are still with us virtually, from being a bricks and mortar and sitting in some incredibly comfortable chairs that I'll show you in a moment in one of our slides that gives you an idea of what we look like when we're in a space. And it has been astronomical to see the continuity in the level of improvement for all of these women and their ability to recover and resume a close proximity to their baseline and experience an enormous amount of relief. And to Dr. Berndorf's point, I just ran a partners group this morning, and if ever there was a time that partners need treatment and support right now, this is the time as well. But to hear them speak to them witness their wives, partners in this time of chaos and being in such an undefined space and watching the woman in their life really use these skills and step up and really improve communication with their partner, feel substantially better, be able to make decisions and navigate the intensity of being home under one roof all the time. It's been really remarkable. So we are very pleased to see that although we are not able to see these women face to face every day as we once did, that the efficacy stands strong. And that I think one of the most critical elements of the virtual day program right now is this sense of community that everybody is so desperate to latch onto, especially just the natural isolation that pregnant and postpartum women feel, that sense of community where they're all in it together and they all understand and can connect with each other's vulnerability and the situations that they're in. So on top of the day program, we're still continue to provide outpatient treatment. So that includes individual therapy sessions, medication management with reproductive psychiatrists. We also do trying to conceive consultations. And to Catherine's point, we have social workers, we have postdoctoral students, we have psychologists, we have reproductive psychiatrists. We have a full realm of very seasoned and highly trained and skilled clinicians that specialize in the perinatal period, which is important. We also have expanded our virtual support group platform. Some of these are in the process of being offered, some of them are. We've always offered a perinatal mood and anxiety support group for new and expecting moms. That is going strong. And you know what's lovely about that group that meets twice a week is that it's formed its own community as well. So there's a lot of the same faces that this is part of what we encourage moms to do so much while they are homebound is to create some structure in your day. And so on Tuesdays and Thursdays, this support group becomes something that's a part of their structured day that they know is going to happen and can look forward towards. We're going to start offering an open partner support group so that partners outside of just the virtual day program, so partners of our OP patients, but also just dads and partners that are out there looking for support, have a safe, confidential place to be able to process what it's like for them. We're going to be running a CBTI adult sleep support group because of the anxiety of the coronavirus. It has really adversely impacted a woman's ability to sleep at a critical time. Pregnancy during the time of COVID-19 support groups. Dr. Berndorf and her colleague Dr. Fiss, who's an OBGYN, did a really, really powerful webinar a few weeks ago that you can find on our website, all about pregnancy, delivery, and the immediate postpartum. If many of you heard, a week or so ago, there were a number of women in New York who were delivering without a partner, alone in the delivery room. That has since changed. The governor has revoked that. But so much concern and confusion about what is it going to be like to deliver a baby in the time of coronavirus. We're partnering with the Pregnancy Loss Support Program to run a miscarriage and loss support group during this time. And a real popular offering we have is called Supporting Healthy Relationships for Couples. This is a empirically proven program, federally funded, based on the Gottman model. And it's for couples trying to navigate parenthood together, and also with an emphasis on the difficulty of doing so in this time that we're living in. And then I referenced a few of these webinar series we've done so far: managing anxiety in the time of corona as a parent, the pregnancy and delivery webinar that Dr. Berndorf hosted, navigating your relationship in the time of coronavirus under one roof. We are constantly providing support and guidance to women and couples trying to make sense of this, where you've got one person working or both people working under one roof, trying to navigate childcare, trying to negotiate. It can be very, very stressful. Mindfulness to reduce stress and worry. We're going to be doing a subsequent virtual day program open house to describe what we've described to you today. Sleep strategies. raising kids at home in the time of coronavirus with attention on special needs children, which can be incredibly challenging for women and their partners under one roof, and infertility in the time of corona. So many of these we've already hosted, and they can be found on our website. And the latter of these will be offered in the upcoming weeks. And then, oops, I just want to spend a moment on this slide here that really does speak to the efficacy of the day program in particular. Many of you might be familiar with a screening instrument for perinatal mood and anxiety disorders called the EPDS, the Edinburgh Postnatal Depression Scale. This is one of the most commonly used instruments to be able to determine the acuity of a new or expecting mom's symptoms. The highest score you can get on this is a 30. On average, we're seeing women enter the day program with a score of 21, a little bit higher than that, especially now, and discharging, leaving the day program with a score less than 8. So this is a marked and significant improvement when you look at the minimization of symptoms due to the intensity of the care that they're receiving while in the day program.
I would just add for one, sorry, Paige, to interrupt you, that women typically stay, we forgot to say this, or I forgot to say this, typically are in the program about 6 weeks, 4 to 6 weeks, sometimes 8 weeks. So the average, I would say, is about 6 weeks. Just so you know how long people stay with us, 5 hours a day, 5 days a week for about 6 weeks.
And sorry for the dog background. We are longing for this beautiful place that we used to work out of. This is what the bricks and mortar version of the Motherhood Center looks like. We will go back one day, but I thought this was important just for when we do go back, for everyone to see, we intentionally designed this facility to feel like a living room and nothing at all like a hospital or a clinical facility, because we wanted it to feel like a womb, which is what many people have referred to the day program as, being held as such. So this is just a few examples. This is our day program where the magic happens. Again, when we're actually there, those are the comfy chairs that I was referring to. Babies are in and out all day long. And this is the nursery, just to give you an example of when we are there, where little babies spend their time with our amazing nursery director and team. And so that is our conclusion for today. Just really wanted to thank everybody for watching. Thank you so much to Bridget and Sonia for hosting and inviting us. I just want to encourage any and all of you out there, if you know any new or expecting moms that are struggling, please, please encourage them to call us. We have incredibly talented and empathetic care coordinators that will answer every call, that will get a basic understanding of what a mom is experiencing. We will run benefits. We will connect you to treatment either with us or elsewhere. But nobody gets off the phone without being connected to care. So you can have people call us at our main number, 212-335-0034. Or visit our website, which has a whole slew of treatment offerings and all kinds of information at www.themotherhoodcenter, all one word.com. So thank you very much. And Dr. Berndorf and I have our contact information there. Please feel free to reach out to us with any questions or any way that we can be helpful. All right. Thank you.